of being here.
All right, then we'll call the meeting to order. Did everyone get a chance to look at the minutes from the last meeting that were sent out?
Yes,
Any modifications, anything else, any concerns, questions?
only the spelling of your name.
Yeah, that tends to be, if you look on the most recent agenda for the meeting today, my name is spelled correctly there, so we'll get it fixed elsewhere.
We'll go ahead with the spell check.
Yeah, if you don't do those ice blinks, so. All right, so motion to approve the minutes of the last meeting? All right, James.
Motion to approve.
Fine.
Do we have a second? All right. I'll make a second. All in favor?
Yep.
Yep. Yes, somebody.
Aye.
Okay, so then move
Aye.
on. Any correspondence since the last meeting? All right, no correspondence, so we'll move on to our old business section. Brandon, would you like to give us an update on the paramedic program?
Of course. So my current program, my 2021 group, we're still holding good with our numbers. We're at 9. That hasn't wavered in quite some time. Last week, we did our cadaver lab experience up at University of Rochester Medical Center. As always, that's a great experience for them. I still really enjoy going, which is commendable to them. 3 physicians leading it last week with 7 cadavers, which although it's kind of morbid, it's the most that we've ever had. So a good experience for everybody. We actually stayed about half an hour longer. Dr. Cushman wanted us to stay a little bit longer, and I had some things to finish up, so of course we stayed. Because the numbers were a little bit lower for my med class, I was able to take some folks from my AEMT, and I took 2 folks that actually graduated last year. So we had, 15 of us in attendance, so great day. As far as our AEMT class, this is the first time we've done the AEMT in quite a bit, actually about 3 years now. I think a lot of the issues with the AEMT, they're ironed out now. I think there's a little bit more understanding of what the level is and how it can be used. That's being held up at Schuyler. Schuyler's been, Patty and the staff at Schuyler have been very easy to work with, and making things easy for us there. 2022 enrollment is underway for our new class. That's due to begin in mid-August. I already have 8 people enrolled and registered. And I think 7 of those 8 are kind of enrolled with the college as well, which is good. So that's kind of a 2-step process. They apply to our program, and they also apply at Finger Lakes. In the future, we have 2 EMT classes planned, original and refreshers, one for here at Elmira at MSTAR, and one up at in Bath at Bath Ambulance. Those applications are at the state waiting for final approval. We don't really advertise until their final approvals come through, so we're just kind of holding off on advertising that, but those are in the works. And what else? About monthly, at the request of Steuben County Sheriff's Department, I do a very short CME review or a skills review with the deputies, with our certified deputies. I do 2 sessions, maybe an hour or so, just reviewing kind of the high points. They are in 100% CME program themselves, and they're very much engaged in that. They still want that in-person theme. So I go up there about every month and, hit the skills that they don't see a whole lot, things that they might feel a little bit uncomfortable, in doing. And that That is about it. Oh, and as we should know, hopefully everybody knows, EMS week is coming up soon.
Great.
We were able to add a certified lab instructor class. The state's authorized to do one more class. We're offering it in the middle of June. It's 2 nights a week, Tuesday, Thursday, and then the following Tuesday and Thursday. And we're looking for great candidates who want to get into the certified lab instructor class.
We'll put on the list.
If anybody's available, we'd love to have some good, highly qualified lab instructors. If there's anybody in the room,
Sure.
would be interested,
When will you advertise that?
we just got approved.
Yeah, well,
So it'll go up this
I
way.
would like, okay.
So let me open the agencies and everything, just to get people.
Yeah.
All right. We've got a good amount, we've got probably 10 or
Good
12
interest.
pre-enroll
Okay.
that we can hold on the names, so hopefully we can get some more highly qualified.
I'm sure Brendan can use the help.
Oh, I get it. Oh, most definitely. Most definitely.
Thank you, Brendan. As far as QI, the agency dependent, I don't think we have anything regional set in place, still looking for somebody, I guess, or.
Terry is the chair, I mean, Rick probably speak that better. Terry is the chair of the QI committee, Rick? You're on
Yes, she
mute.
is. Yes, she is. She's the chairman of the council's QI committee. That's correct.
The state is gonna push the issue, reference that thing I sent you yesterday from the.
Yeah,
from
the trauma services.
The states, it came up again, and they're gonna start pushing the matter for those QI studies, and particularly they're tying that to the new EPCR program. So they're gonna start putting some people under the gun to see some results here.
Just with the EPCR that they're pushing, it'll be easier to data farm and get the information for us as well.
Yep.
All right, also on the old business, I sent the email out. The policies, the STREMAC policy. I got the list from Dylan Kellogg about what everyone's assignment was, what everyone volunteered to do. Later today, I'm gonna send out your assignments, and we're also gonna send out a copy of the policies via email. That way everyone can take a look at them. Some of them need to be refreshed, some of them probably don't need to be refreshed. Just take a look, glance over it. And if there's any changes that we have to make, just email back your individual policies with the changes. If everything looks good, still please reference the email and say that this individual policy looks okay. That way we can say that we've looked over everything and make sure there's no updates that have to be made. So that'll come out later today from either Mike or myself. Everyone's name will be on the email, and it'll also have the policy that you're responsible for. I think for everyone, it was like 2 or 3 different policies. Most of them are not much more than a few paragraphs. Take a look, see if there's anything that has to be updated. If it does, make the update. If not, just say policy looks okay. And then the next on the old business is kind of old/new. I'm gonna turn it over to Rick Kimball for a little while, talk about the COVID vaccination. The old part is they're still continuing to aid the county with our efforts to vaccinate as many people as possible. But Irway has also taken on an endeavor of visiting people in their home. So I just wanted Rick to talk about it a little.
Well, for Irway Ambulance, we've actually been quite busy since February with vaccinations. We've partnered both with Arnett Health as well as Chemung County to be active participants in their mass vaccination and pop-up clinics. Since the 1st of February till the April 30th, we've committed 940 man hours and given 6,855 injections, either at the Arnett's mass vaccination site or at the county's mass vaccination site. We've also done some pop-up clinics, Elmira College, Venetton Fire Department, Ira Davenport Hospital. There's been a bunch of different pop-ups that we've done for a total of 93 clinics, individual daily 93 clinics that we've participated in. Since the beginning of April, we received approval from the Department of Health for community paramedicine. And on Fridays, we partnered with Arnett Health, and Arnett Health physicians from Arnett Health or any physician can recommend to Arnett Health that if if their patient is bedbound or is unable to get out of the house, we will send an ambulance to the house on Friday and give the vaccination. So since the 1st of April, we've committed 55 man hours and given 47 vaccinations to people in their homes. And we're giving the Johnson & Johnson the Janssen vaccine in homes. When Janssen was on hold, we did Pfizer for 1 week. So we'll have to go out and do a second Pfizer here in a week or two to get the people their second doses. But it's been working very well, and actually quite proud of what we've been able to do. After seeing so many COVID patients in the community, it's definitely our intention to get as many shots in arms as possible. And that's essentially it. I know of no other agencies in the region that's doing that, but if any of the other agencies are interested, we're more than happy to help share. I'm more than willing to share our application to the Department of Health. So all they have to do is change names and do their submission.
All right, thank you very much, Rick.
Thanks so much for doing that, Rick. That's wonderful.
You're welcome.
Absolutely agree. It's a great initiative.
Well, let me tell you, it's as paramedics and EMTs, we really don't get. I don't want to say that we don't feel appreciated, but there's definitely it's so much better to go out and to be giving something to somebody that they want, and having that interaction. I've gone out to people's homes twice so far myself, and had lots of really good conversations with people. Matter of fact, last week I actually sat down and spent an hour with a Holocaust survivor and listened to her stories for an hour. So it's definitely a different side of what I haven't seen in the last 27 years of being a paramedic. It's a completely different side, and I really enjoyed it.
Rick, do you remember in class they told us we were going to be doing that back when we were in class?
Oh yeah, I remember that, and it never went anywhere. And then, pow, here it is.
Yeah.
So, and I really honestly believe that EMS is ready, willing, and able to do this. And I think that we've proved that here, at least at Airways. And I know there's other counties in the state that are doing this quite successfully. So I hope this, after COVID's over, I hope they continue to use us in these types of situations.
Just to add on that, Airway Ambulance was one of the first in the state to be granted a community paramedicine program. Also, they're the only one in our region. Currently, 39 agencies in the state. Airways was one of the first ones to be granted.
God bless you, Dr. Sheriff.
Thank you.
Is there any questions about what we're doing or how we're doing it? I mean, I can answer any questions.
Well, Rich, if you need any help, I'll be willing to help if you need anybody to go out with you or in the clinics. I'm helping out up in Schuyler County, so.
Appreciate that, Dr. Sheriff. Thank you.
Okay.
So like I said, the offer is out there to any other agency that wants to start doing this. I'm willing to share our application or any of our processes and how we got to here. Okay. Thank you.
Thank you. I think that about wraps up all business unless anyone else has anything. Otherwise, we'll move on to, I don't see, is Don, Ed, or
Ed and Brian are deployed. Don is detached and deployed, so I hope they would be able to chime in, but it doesn't look like they were able to.
all right, quick part of that meeting.
Don?
So then, Mike, do you want to talk a little bit about the introduction to the protocol app and then introduce Stephen?
Okay. New York State put out for bid, and they want to do their own version of the protocol app. If you recall back a while ago, the region program agencies put out a protocol app, and I believe it was bought into by everybody north of the Tappan Zee. And it came time for that to be refreshed, and the state said we would run afoul, and they were going to do it on their own. So they have done that, and they contracted with recently Muru. And we're lucky to have Stephen from Muru, who's going to give us a quick overview of the program and tell us what we need to do next, I guess. So, Stephen, it's all yours.
Great. Thanks for having me. I appreciate you guys taking the time. So let me kick right into the presentation, and we'll answer questions kind of as we go. All right. So Muru stands for Medical Guru. I was gonna call the company Moda Medical Yoda, but it was a little too nerdy. So we kept it with Medical Guru instead. To give you a little bit of background, we're a team of paramedics and engineers out of New York City. I've been a New York State paramedic for the last 14 years myself. A lot of the guys on the team have been as well. Now we're remote, but we used to be at 14th and 7th in Manhattan. So we're very much, built and created in New York. So to start off, when we talk about EMS software up till now, we see that a lot of EMS software has either been inherited from either other first responder agencies, right, fire, PD, or from the hospital system. But very little EMS software is truly built for the level of sophistication that it needs to be to really back the providers up where they're out in the field. And so with that, when we decided the first topic we were going to tackle, we really thought about protocols. And protocols, as they stand now, we say that a protocol is digital, but the way we talk about a digital protocol is that it simply has gone from paper to digital paper, right? Otherwise known as a PDF. That's not truly digital. It's just taking a piece of paper and just making it so you can see that exact same piece of paper on the phone, right? The computer can do very, very little with it. So what we decided to do is to really add value to the protocols that all of you are writing and putting all this time into by truly coding them and seeing what the software can do once it truly understands what it's looking at and processing. So what do I mean by this? Right now, in any protocol set that we work with, right, when I ride at my agency out in Nassau County, right, document, everything that's in there is scattered, right? It'll say refer to your manufacturer's recommendation one place, right? Until recently, pediatric and ALS and BLS protocols were in different documents, right? We may say refer to something as from the AHA, right? So everything's kind of in different siloed pieces of information. We have to look through different documents, find different things. And even though they might reference each other, you can't really pull all that up at once. On top of that, when we do get to the right protocol and find what we need, the protocol can't be specific to the patient, which means that we have to leave calculations in there for providers to do live and in the field, right? So X amount of milligrams per kilogram of patient body weight converted from pounds to that, figure out drip sets, anything else. And then last but not least, we're writing these protocols for every level of provider, which means that every level of provider has to see all the protocols instead of just seeing the things that apply to them, right? So that can come from anything from looking at paramedic level stuff when I'm an EMT versus looking at community health paramedic stuff when I'm only a paramedic versus talking about the benzos that we could be using even though my agency only carries 2 of them, right? And so all that kind of happens right now because everything's in paper. So what we did is we built an app that kind of solves both of the major problems we're focusing on here. One is that it takes all the information from all those different areas and brings it into one single place, right? That your provider knows that anything they need while treating the patient in the field, they can go to one location and all that documentation is going to be there. And then the second half of that is making that documentation really fast and easy to access. And I'll show you exactly what I mean by that in a second. But being able to say that you don't have to go through any training on the software, you can just ask it any question under the sun and it understands enough about you, your certification, your agency, everything, that it can just answer any question you have about anything on the left-hand side. So to say what we cover here, so the protocols look at everything from what regionally is put out to what the state puts out and anything that either of those sources reference. So if you reference the AHA, if you reference manufacturer recommendations, all of that gets pulled in. For equipment, it asks the providers at each agency to list the equipment that they carry, knowing that the protocol set leaves open slots for different equipment that you may use. And then it pulls in all the manuals and equipment and everything for that. So every manufacturer recommendation for any product that the agency carries will be in here as well. Same thing for the hospitals. Every hospital, it's like a EMS Google Maps specifically for that. And every hospital can maintain their own content on there to get extra information to the providers so that they can go to one place and know that the hospitals are keeping that data up to date. And same thing with medications, right? You can look at meds, and I'll show you in a sec, find out all sorts of information about the med you carry. And if the state or a region decides to implement the formulary again, it'll be in there as well. And then with rapid access, I'll leave that part for when we get into it in the actual demo. So a few more quick pieces of information about technology. Everything about the demo to you works completely offline. There is no need to have the internet except for when updates happen. Everything's going to be individually personalized. So when someone signs up, we know the protocols that they're following, the equipment and meds that their agency has, and the level that they're certified at to operate. And again, if they operate at different levels in different organizations, that's fine. Everything in the app is only for that, only from trusted sources, meaning that it's, this isn't a WebMD where everything you type in says you have some weird form of cancer, right? It's more focused on, anything that is authorized by their medical director, by the region, by the state. So nothing in this app is being pulled from a non-quotable source, right? If it's not coming from a source that you guys specifically stipulate, it doesn't happen. And as I demo the search engine right now, what you'll see is it does something called natural language, which means that no matter how a provider asks a question, it can be one of 50 different ways, it'll understand what that question is and immediately answer it. So with that, let me show you what we're working on. You should be able to see, did the phone come up on the right-hand side of the window?
No.
Nope.
No? All right, let me fix that then. 1 sec. No worries. Just do this. All right, now you should see the phone. All good? Okay, great. So when we open up Maru, you'll see right in the upper right-hand corner next to where it says Maru, there's an agency icon next to it. If you click on that, you can add any agency you're part of, right? Here's just a smattering of the agencies I'm at. I'll leave it at the one I currently ride at. And you'll see a whole bunch of agencies in there. When you click on one of them, you'll see it distinguish it by paramedic or EMT or whatever other level you are. You can click it, click apply, and immediately swaps over to that agency's profile. So to start off with what we can search through, I can type in just about anything here. So an interesting thing is that when I type in diabetes, it knows that diabetes isn't one protocol for a paramedic, but two separate ones. It recognizes that as a condition and finds both protocols that may be applied to you, at which point I can click on either one of them and pull up that specific protocol coming from the state, right? Flip my phone sideways and scroll through it. What's interesting, especially with this particular one, is if you do a word search for it, right? Just Control F when you open up the PDF, the word diabetes only comes up in whether or not you're allowed to establish an IV in the state protocol set, which means that for any provider that actually searches for the word diabetes, it results with nothing in particular, right? Versus when you search through it in here, it immediately pulls up that information. From there, I can type in something else. Let's say asthma. When I type in asthma, I'll see the asthma protocol, but I can then say, it's for a 7-year-old, and immediately finds that there's a pediatric version of the same protocol available. You'll see how it's swapped out to the word pediatric. And when I open it up, you'll see it's the pediatric asthma protocol instead. From there, I can then say that I want to give them a medication. Let's say we've done the first few combi vents, it's not working, and we have to go to something more intense like epi. I can type in epi and immediately pull up all the epi doses that come from that pediatric asthma protocol. You see you have your first dose here for critical asthma attack, first dose for just regular asthma wheezing, which requires medical control approval, and then a second dose here, which is an infusion. And as you can see, all this stuff is weight-based. So I simply type in any weight for the patient, let's say, I don't know, 43 pounds, and immediately calculates all my med math for me, including a full infusion set that shows that we can run the epi at 1 to 1.5 mics per kg per minute. And then in the bottom, by combining these things, right, out of the saline bags I might carry and out of the drip sets I might have, this is the best combination of those things to put together to get you to 1 drip per second. I can click on it. Oops, sorry. I can click on it and scroll around to any other level. And as soon as I release it, it picks the another best set possible to get you that 1 drip per second count. If you go inside any of this, you'll see that not only does it give you more information on the dose, but it includes live dosing calcs of everything that's going on. So that's that piece of it. When we do the search, you'll see it pulls out the 7-year-olds and the 43 pounds from the top. So now if I clear out the search by clicking the X in the upper right corner there, any other question I ask is now customized to that patient. In addition, if I don't know the patient's age, I can just click on the human in the corner and type in a DOB or anything else, and it'll auto-calculate that information for me. So that's that piece of it. Going into hospitals and other things like that. So first, let's show protocols. So protocols here for me in Nassau County, you can see it's a smattering of all the protocols that are coming from either the region or the state, all combined into one set. Moving over to hospitals, it will classify every hospital either by nearby or any capability that we list. So these lists is specifically, done for New York State. If there's any specific capabilities your region additionally adds on or certifies hospitals in, those will come up for any provider that adds an agency in your region to it. So if I click on one of them here, let's say burn, it GPS sorts the burn hospitals from where we are and will show me the closest ones to me going down the list. You can kind of see them here. This is a demo phone, so the GPS is slightly different. You'll see it's saying I'm not exactly where I am. So you can see all that here. It'll show you the burn hospitals. You can then click into any hospital. It'll show you a photo of the hospital if it's there, all the information on the hospital, any capabilities that are added to it, where to send the EHR to, and any other information that that hospital wants in there. In addition, at the bottom, it'll list all the sources of where we pulled that from, so a provider can spot check it. The same thing works here for equipment and meds. So I can pull up a list of medications I have, and this is specifically to my rig and what my agency carries. I can click on one of them, let's say fentanyl, and it'll show me the picture of the fentanyl vial that we carry, the concentration we carry it in, and then every time that vial is used, whether it's pediatric, adult, pain management, anything, you can see them all right then and there live. If there is a formulary available, that formulary will also come in here. I'll just show you a quick example of that from another organization. So let me just pull up the fentanyl. If the state or the region ever chooses to go with a formulary, you'll see here that the formulary comes right into the line and will list all the formulary information as well, quickly available to them. So let me switch back. Last but not least, we have equipment, and that pulls up all the equipment available. So if we go to CAT Tourniquet, it will specifically know if the agency carries a CAT 5 versus a CAT 7 generation. It'll show you all the information on the CAT, including a manufacturer recommendation on exactly how to use that generation of the product. If they put out a PDF, it'll be a PDF, which means that it'll continue to work offline. If they only put it on an online source, we'll directly link to that, so it'll open up in their browser window. And you can see it goes right through it here. Not only does it apply for that, but it applies for more complex stuff, obviously, like a cardiac monitor. So it knows that my agency carries the Zolac series. And so it'll give me all the information on that, including where I can cardiovert, pace, defibrillate, anything. In addition, the manual. And not just any random manual, but the most current version of that manual, right? We're on revision D of the X series monitor at this point. And so all that's in here. A few more quick things to show before I kind of move on. We also have on the side here a bunch more information that will include a directory. The directory will pull information that both the state puts out and you put out on phone numbers you would like in this directory, so that people have that information available to them. And then we have the ability here to get any help they need. So if they have any question on the product at any time, they can live chat with any one of our medics. One of the docs actually reached out to us today on this to ask about setting up their account from you guys. And so all that's in there. You can either live chat or go directly and find answers just in the help flow down there. And last but not least, any other information that comes in from here, anytime you guys update any protocol, anything you want to change in the system that you want your providers to notify of, instantaneously notifies all providers in your region. If it's only for paramedics, it'll only notify the paramedics. If it's for all provider levels, it'll notify everyone. If the state updates a protocol and that protocol is being followed by anyone in the region, obviously, it'll notify everyone instantaneously. So there will be no more trickle down of the protocols, hopefully eventually getting to the right people. This will be an instantaneous notification of every provider that has Maru on it. And that's not whether it comes from your agency or from the state. So that's that. Any questions about the app before we go on to more of the business model piece and all that? Okay, great. So just going back here for one sec. Go back to the presentation. So just talking about benefits for kind of what we're bringing to both the REMSCOs and the SEMSCOs. This is really both, it helps the provider keep updated, but it also really, we consider ourselves providing two services, right? One to the REMSCOs and the SEMSCOs, one to the actual providers. One is that, as I just mentioned, these protocols now, no matter how many people download this app, will instantaneously deploy all this information custom built to each provider's profile to them right away. Anything changes, it will only take seconds for the notification to go out to every single provider in the region or in the state, depending on what the notification is meant for. We hope to have a really great working relationship with you guys and know that any information you need, will always be able to be in there. And now you will not have to go out and run and try and compile all the information together. We will do as much of that work as we can help with to support that, including giving hospitals the ability to upload their own information right into that system based on the parameters that are being set by you and the state. And then last but not least, there's no onboarding, right? So we're going to be able to work with every agency, every provider. We're constantly putting more and more effort into making sure this is very easy to use and understand. And we consider this just version 1 of what the state version is looking like. And then we will continue to increase it from there. So we hope that when anyone picks up this app, we'll instantaneously walk them through how to use it. It'll be so simple and easy to use that there's really no training and no learning curve, but we're going to try and reduce as much as possible. A few more things about the feature sets and what's available. So we've actually been out in New York for a little while now. We launched just around the time that COVID hit. And so for all of COVID, we've not collected any revenue from anyone at this point in any of the levels or tiers. We've made our top tier, our agency level, completely free to everyone. The statewide version includes most of the things I demoed for you today, right? So you can browse through everything, those 4 buttons, all the offline notifications work. The notifications will push out, all the offline functionalities there, and all the content, no matter whether you work in a region that follows the state protocols or not, will all be in there. We hope that at some point in the future, then when COVID finally does close towards the end of the year, we'll offer other tiers that are available to the individual or the agency to purchase, if the agency chooses to. And if they do, great. And if a provider wants it and their agency doesn't go ahead with it, they can purchase it as well. And for the agency, they'll get all sorts of other insights that we'll be making eventually free to you guys as well as soon as we're done getting it all up and running, which will be insights on how the protocols are being digested, where people are struggling, not individuals, but as a whole, where your providers might be struggling with certain protocols that they're asking a lot of questions on, things like that. And so agencies can get that, as well as custom other notifications and other compliance reports that they may want. And so talking about setting it up. So from here, our real goal is, again, to just have a working relationship where you can reach out to us at any time, right? I'm the CEO of the company. So if you ever have a question, you'll all have my personal contact info that you can reach out to me and ask. We'll set up a contact there of who we should be reaching out to for questions, especially when anything you want on the app is ready to change. We will prep that and make sure it's ready to go days before it gets voted on. So when it does get voted in, we're instantaneously able to publish that notification. Once we're all set up, we'll let everyone can actually have access as of right now, go through it, make sure you're happy with all the content in there. We'll then make sure your contacts are up to date. And then after that, we're just going to, through your organization or however you want to set it up, we'll reach out to all the hospital ED directors, make sure they have any information on their hospitals in there, and we'll show them exactly how to update if they'd like to change it. And then just get everyone on the platform and kind of let everyone download it. So it's currently available on iOS and Android. There's no trick to it. You just go to our website, sign up for an account, and when you download it on iOS or Android, you just use that account to log in. And you can log in on as many phones and iPads and anything you want. So that's Maroon.
So Stephen, just to be clear with everybody, because I see people here trying to, you have to go to your website first to set up an account, then
Yes.
go down from.
Yes. So when you log in online, we ask you a series of questions to make sure you're set up with the right agency, right level of provider, all sorts of stuff like that, and that will issue the account. If you go to the website first, it'll send you directly to your iOS or Android store to download the app. If you go to the app first and you try and log in, it'll simply tell you go to the website and fill out an account. So regardless of how people are instructed, we made sure that they all get to the right place either way. Right in the first login page, it says, hey, if you don't have an account already, here's the website, go there, click get the account.
So I'm actually trying to register right now as their medical director and physician. There's nothing on here. It just says AEMT, certified first responder, driver, EMT, and paramedic. There's nothing
Right.
for the
Yeah, so we haven't created a medical director level yet. What we're going to do for all of you, especially the medical directors of agencies and organizations, we are going to set up for you guys specifically a separate agency, specifically so you can preview protocols in the system before they get published to everyone else. So if you have anything that you would like privately done in here, we can do that. We can deploy it to you guys in particular. You can make sure you like how it looks, and then it will be deployed to everyone else. Right now, the levels of provider are the levels being given by the protocol set that they're aligned with. So If you just want to see kind of top level, then everyone should sign up as paramedic. We will then issue you guys additional credentials after that. And we're also making a community health paramedic level as well. So if you want to write any regional protocols on that and then tell us which agencies have that option, then those providers can log in and see that additionally. And if they're regular paramedics, not community health, they won't see it.
So what about the medcoms? And I don't know the logistics of what goes on RN or RPH. If you're at medical control,
Mhm.
can they look at that and just kind of make sure that they're on the same page? How do they look at that?
Sure. So we can actually give medical control providers can have the same login credentials that everyone else. We can actually swap it out so they can switch between BLS and ALS if they want to at any time. And so they can look at it differently in different ways. But regardless, they'll be able to pull up the protocols and see what's going on. So we're happy to, right, we'll handhold them through getting it set up if there's any issues there, but anyone can sign up for it right now and get access. And then that's that. We do not actually provide, right, you're not communicating to medical control through us. Any phone numbers in there just push back out to your regular phone. Same with navigation for the hospitals, right? It just pushes out to whatever navigation system you're using. So we tried to make it as stable as possible in that way. But yeah, we're happy to set up medical control however you would like. You just let us know. Like we really are, when I say like New York's like, this is our, we're working with you guys however we can to make this as best as possible. And there's a whole team of us working on it 24/7. So any feature requests you have, any suggestions you have, just let us know.
I would just say this, from my experience so far, the technical support is nearly instantaneous. You'll get technical support like this anywhere.
Thank you. I
Yes.
appreciate it. We really try and make it as like to just right to really be transparent, right? It's great if you have all this content, but it's always scattered, right? So at least now it's all in one place. And then you really can't use it live in the field if it takes more than 30 seconds to access it. And so really it's 2 points, right? Point one is get it all in one spot. And again, here with the hospitals and everything else, we feel that we're bringing that to a level that hasn't really been achieved in a protocol app before, right? Every hospital being able to have their own state on their page. And then rapid access means that when I'm riding in the field at this point, it takes me 10 to 15 seconds to pull out my phone, get my answer, put it away, right? And every answer we give in that search is what we call actionable, meaning that there's nothing left to do except go off and execute it. So we're really trying to give a tool to the paramedics that they can really use.
It runs in offline.
Yeah, Steve, we were
Offline.
runs offline, so we don't need LTE because,
Nothing.
very
So we actually have been, funny part is I designed this initially just because I've been in basements before where I don't have access and I can't like turn to the family member and be like, hey, what's your Wi-Fi, right? And, simultaneously been working with the military as well. So they use it on a much larger scale. Everything on the phone I demo is completely offline except for notifications. There is nothing. So if the phone goes offline because you get abducted by aliens, you are operating as a paramedic at that time and that day when you got abducted until you get brought back to Earth and your phone connects to the internet again, right? So everything about search, there is no lag, there is no delay, there is nothing. It is all completely on the phone. So we have to build, we invented a search engine that works entirely on the phone without any need to access any server.
No, I think it's really impressive. I mean, as someone who teaches our paramedics, the one thing that really, I think, still haunts most medics is med math. And just being able to put in, I've got a 7-year-old that weighs 43 pounds. He needs X, Y, Z of epi, or here's his drip, or that takes probably 99% of everybody's angst, especially on kid calls.
Thank you. I really, yep. I couldn't agree more. Thanks. I really appreciate that you like it.
Is that component similar to hand tabbies?
Yeah.
Similar to what? Antevi?
Yeah.
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 So I don't want to speak about another organization's product, but we try to make it live and dynamic, meaning that it is completely customized to that exact patient at that exact time and their exact protocol set with no lag. So the moment you give us a new protocol or just a new dose, right? Let's say we go in dopamine. I'm dating myself a little, right? But let's say we go in dopamine from 5 to 20 and we say, or from 1 to 20 to 5 to 20, right? The moment that happens, everyone's phone immediately starts calculating based on that new piece right there. And it's live weight-based calcs, right? There's no pre-built-in thing. Every protocol is different, which means if that dopamine we might use might be different in different protocols throughout the protocol set, it's not one dopamine calculator, right? Everything calculated is customized to, if that provider is allowed to do it, the concentration that's carried in their ambulance, the dosing of it in the protocol set, and that specific protocol's dosing, right? There is nothing to consider when you ask the question that we're not taking into effect, right? So that's significantly more customized than anyone else we've seen out there so far.
When you talk about dosing of the concentration that's carried in the ambulance, what we found over the past few years is that meds go on back order. So we're forced to get different concentrations or different type of delivery, different ways to deliver that medicine. Is there an option within the app to be able to alter? Say we weren't able to get the 1600 mic bag of dopamine that we had to get, whatever, is there a way to alter that within the protocol?
So the short answer is yes. Right in the app, open to every provider at the organization. If there's a button that says manage inventory. So the moment the inventory is swapped out in the organization, the org can swap out what concentration they carry or what size of it they carry, and it will immediately swap out for all providers at the organization in the background. So as soon as that phone reconnects to any internet access, it'll swap it out right then and there. We don't have it. We are still building out a better version of that coming soon, but we're still tweaking it. But yeah, so they can swap it out in the organization, and we also have the ability now where you can see multiple concentrations at once. So for example, take your standard epi for ACLS, and you can see the different ways it's carried in vial and in compound in all sorts of forms. So it's all
because there may be times where there's multiple different dosings
no, 100%.
in an agency at a time, because especially with the smaller agencies, we don't we don't stock large amounts of the medications. So we may have, in 9 of the 10 ambulances, we may have one concentration where in one ambulance we just happen to have a different concentration.
So one of the features we are building out that we haven't finished yet is rig specific concentrations. That does not exist yet. So for example, in any organization that runs critical care ambulances and regular ambulances, we're currently listing them as 2 different organizations, right? That the critical care providers are working in their own sort of field. We are going to make it ambulance specific soon. So that's a really great point. It's definitely something that we're working on now. The only other thing with that is if at any point anything isn't customized the way they want, they can always go straight back into the dosing calcs, which are line by line exactly how we got there, and they can manually pick it up from any point in the system. So if there's ever a problem, Muru's entire fallback plan for everything is you're always only one button click away from the original protocol. You're always only one button click away from auditing anything we've done. And so that the providers can always see everything in the backup if for some reason the feature didn't cover it right.
So does Irway Ambulance have a different permission level than Mike Medic that works for Irway Ambulance?
The ambulance company itself?
Yes.
So that would be on one of the premium features, right? So if the organization wants to take control and manage the organization, that comes in the upgrade.
Okay. So
right now it's completely open. Anyone says whatever organization they're at, and it just adds it, right? There's no check. If the organization wants to take control, then the organization gets the upgraded version for all their providers, and then they get far more control of the system at that point.
So in your pricing graph there, it was an individual is $8, an agency is $8. Is the agency $8 per provider or $8 per agent?
No, $8 per provider.
Okay. So I got 50 providers and it's $8.50 per.
Right. And the real goal is that organizations that know if it's a small agency, we're not charging them a prohibitively large cost, right? Like that it's scale, the pricing scales to the agency. Otherwise, right, it would just be some general cost for all agencies regardless of size. So we try to make it scale based, so small agencies pay a lot less than larger agencies. And if the agency doesn't want to go ahead with it, it doesn't block the provider from getting those additional features, right? But if the agency wants, you know, QA compliance and all these other great features that we have for them, and, you know, control all of that as well, in addition to just giving a great app to their providers, then we add all that in as well for the same price.
So to that end, are there any economies of scale? Let's say I've got 100 providers.
Mm-hmm. So no, not at any level like that. We tried to keep it a pretty straightforward pricing point for now, pricing model. So it was very easy for any organization to just know what it was without having to talk to a sales team or anything. So no, it's pretty just straightforward. 100 or 10 or 5, it's all the same.
And one more to tease out that back out a little more. So let's say I have an agency and I have 25 paramedics and 25 EMTs.
Mm-hmm.
I can upgrade 25 paramedics because they're the ones who are going to dig the deepest into this, and leave my 8 or my EMTs at the basic level.
So in theory, yes, we would then just make 2 separate organizations, right? One would be free and open to everyone, and the other organization would be specifically for the paramedics. And then they could do that. I would say though, based on what we're seeing of use, there's 2 really important features. So, and it's funny because it comes up all the time for ALS, for anyone who is ALS, right, including physicians or anyone else, right, they see the dosing calculator and they say that's the most important, valuable piece of the premium version, right? For BLS providers, though, we find that what they use it for the most is locating the right protocol at the right time. So they're looking for which protocol should I treat this specific condition or symptom under. And the fact that we can surface that to them within a few seconds is a reason a lot of the BLS providers use it. So the top ALS feature is dosing. The top BLS feature is what we are calling protocol finder, right? Which is any symptom, any condition, anything, right? You don't know if there's a CO protocol or not. You don't know if it's under AMS or, you know, a hazmat protocol or anything else. You're not sure where. You just type in CO, and we already have that properly mapped to the right location, and it just gets you there within a second or 2. So it's up to the agency, but yeah. And then the agency also gets all this other feedback, right? So if a hospital changes the capability and it pushes out to all their providers, the providers can then not only see the notification, but tell their agency they got it. And so the medical director can log in 4 days later and go, oh, you know, look, 98% of my organization already updated without me having to do anything. So.
Okay. Thank you.
Thank you very much.
Thank you.
No problem. Great. All right. So I'll follow up with you guys soon to figure out who the point of contact is. And then, you know, we'll just get everyone up and running however you would like. The pricing point being separate, right? It's free for everyone in the region. And so, you know, we're just looking forward to working with you guys and getting everything squared away.
Thank you. Thank you, Stephen. We appreciate it.
My pleasure. Take care.
So I'm going to move on. Next part, the EPCR initiative. As the applications have been coming in complete, Mike has been in touch with Rick and I just for the endorsements overall. And I think how many do we have completed at this point?
Oh, gosh. So we've probably got 40 or so.
Okay. So we're just waiting for a couple more.
Yeah. But we're going to start, once they've gotten your endorsement and council endorsement, we're going to start farming them up to the state to process through. So from your end, we just need a motion to endorse.
Sure. So since it's a state initiative for the EPCR, then all the agencies are moving forward with the EPCR. As long as they're complete, I have no problem giving the endorsement. I'll give my motion to endorse all completed applications to be moved up to the state. Do I have a second from anybody?
Second.
All right.
Did you
All
hear
in
me?
favor? Yep. That was Mark.
I'm in favor.
Anybody opposed? All right, so as long as the applications are complete, then we'll give the council endorsement to the STREMAC endorsement to move it up to the state. This point, last item on the agenda, open forum, any questions, concerns, anything else? Mike, you got something?
We want to talk about the
Oh, yeah.
PCRs. Should they be doing them?
So this is a question more for the medical directors. I know Dr. Herman has been more active than some with kind of not coercing, but strongly suggesting that their agencies complete the EPCRs for all encounters. I have no problem also just suggesting to them that they complete the EPCRs just so that we have a paper trail so that people can see the care that's being given, and it's just the standard throughout the state then. I don't know if you have any feelings about not completing the EPCRs, or if everyone is in favor of just the council suggesting to all the agencies that they complete the EPCRs.
Are you talking about instituting an EPCR program for every agency? Or are you just talking about if they have EPCR every time their wheels roll that they complete a PCR?
D, all the above.
Yeah,
Because the state has a requirement that there is a medical record is required for every time an ambulance's wheels roll. So, I mean, that's in public health law. So if agencies are not producing PCRs for whether they have a patient contact or not, I mean, you're required for standbys, you're required for calls canceled, you're required for patient refusals, and you're required for transports to complete some sort of medical record. That's one thing. But if you're strongly urging agencies to switch from paper PCR to EPCR, that's a complete different thing. I just wanted to know which one we're doing.
Well, it's both. Understand that 1202 and 1203 require transports to complete PCR.
Right.
BLSFR, not so much. So first off, everybody has to go to electronic. State will no longer take a piece of paper after June 1st or July 1st. So they want everybody onto an electronic platform. The second part is they put a hook into, they want BLSFRs to report as well. For two reasons. Number one, because there's some good data there to drive. And number two, continuity of care. That was driven largely in part by the trauma center wanting to know what that first impression was and what was done and those sorts of things. So they want this start to finish. The state has made it semi-attractive for everybody to convert to EPCR. They've eliminated the paper PCR per se. So I guess what we're looking for is the medical directors to encourage, implore, whatever word you want to use, for all of their agencies, BLSFR or ALS or just ambulance transport, to participate in the PCR program. I mean, there's no good reason for them not to, except that they sometimes feel like that they can't or won't or don't want to. There's not a good worldly decision to not do one.
So can we have the council tell them that all the medical directors strongly urge them to go to the electronic PCR?
Well, that's what Dr. Wislenski brought up is the council the STREMAC council can make a recommendation. The medical directors can make it a requirement. So if I fall under Dr. Berry, he can, as a condition of me falling under Dr. Berry, he can require me to participate in the PCR program. So I guess we were talking about some sort of encouragement coming from the STREMAC council, and then of course the buy-in from the medical directors. It really is on the wisdom of the medical directors, because it ultimately falls back on them.
as far as I don't really have the ability to force them, but the medical directors would be able to then suggest to their agencies, in order to comply, in order to improve patient care, in order to improve patient flow from one agency to another and ultimately to the hospital, that we could, in the interest of patient safety, making a recommendation that we would strongly consider as rapid a turnover to EPCR as possible.
Yeah, I think that the medical directors and should work, we should all work together. I mean, the medical directors are part of this. Most of us are part of this, so do it one and the same. If the council says and the medical directors say, then it has to be, right? Otherwise, they'll be out of business because they won't have a medical director.
Correct, and that's the hook that we look to put into it. By the way, it's coming down the road where the state's gonna require them, but in the meantime, in the interim, you know, the cart got a little bit in front of the horse here from the state's perspective, in that they want to require it. They found a couple of different ways to require it, but not 100% foolproof way to require it. So they're in the process of getting that into regulation. But in the meantime, in order to keep their initiative moving along smoothly and to meet those deadlines of going electronic and eliminating the paper, you know, this is our stopgap measure, I guess.
What is the cost associated with this for like a small BLS agency? Nothing?
Zero.
And it's a no-brainer. I think we should require it.
They actually also put out a state platform, a couple of versions of a state platform. Now you can buy it, of course, you can buy enhancements to it, but it's sort of pretty easy. And we've done what we can do to support the program. It kind of wipes out that short form that some were using or patient care summary. So we produced one for them to use in the interim, but I sent it out a while ago. The patient summary form or short form, whatever they want to call it, collects, from my perspective, it collected 3 different things. It collected the state's data points, which the agencies need. It collected, and I spoke with a couple of larger agencies like Airways and asked them what data points were important to them when you hand off. So we highlighted those in red on the short form patient care summary. And we also took some input. A couple of docs weighed in and said they would like to see a couple of data points collected there. So we did that. So we covered the state's data points, the handoff agency's data points, and the STREMAC data points that we all wanted to collect. We also added in so they could eliminate a piece of paper, we added in a refusal. So they could sign off on one piece of paper and we kind of short form the short form. So I think we got to a sweet spot to get us everybody up and running. And again, to do the state's simple level, there's no cost at all. If you want to go mobile, there's a cost. If you want to add on different things to it, there's a different cost to image trend. But it is pretty simple. The basic level is 27, they have to enter 27 data points, largely demographics. The second level, which is where we try to get everybody to, it's pretty much a PCR. I think there's only 50 or 60 data points. And I'm not sure how many data points are in the full version, Rick. Do you know off the top of your head?
You muted yourself.
You're still on mute. At any rate, if they were to go to a full version through Zoll or ESO or whatever the case.
There's over 300 data points on the current NEMSIS version.
Those are all, and by the way, those are all NEMSIS data points, which is what the state is trying to harvest there. And you know, the position we've taken is data drives decisions. That's what supports the different programs, the Narcan program, whatever the case may be, those sorts of things. So all that data is important. So also the state's version, they've also made it kind of easy in that they're pre-populating a lot of things. So over the course of history, when they get a little bit of history on an agency, it'll pre-populate frequent flyers. It'll pre-populate your most common, like a lot of your most common answers. So they'll need to override, which is easy. It's a drop down, but it's pretty easy program. So we really, when they get in and play with it, we're not getting a whole lot of pushback. And I can tell you, we had to do it for the NAC, the National Ambulance Contract that they deployed down in Fort Totten in New York City. They did paper PCRs and sent them to program agencies like us to input these things. And we found that in the process of learning, we got it down to about 9, the average time, about down to about 9 minutes, which is not a large time. Now that's factoring in full codes, and that's factoring in no loads. So 9 minutes is really the median there. We can get one into the system in that. So we've tried to overcome every bit of resistance that it had, but the only one we can't overcome is I don't like to kick computers. That we can't overcome, but it's easy, it's simple, it's painless, you know, it's unfortunately, it's the way things are going.
I want to bring up 2 points about this, but I want to preface it with, I want to state that I'm in support of electronic PCRs and everybody putting as much data into the system as possible. My first point is that no matter what option you pick, this is not free. They're going to have to buy computer equipment, and the volunteer agencies are going to have to have manpower hours or man hours used to enter in these PCRs. And second thing is that a few years ago, we put out a survey, the council did, trying to encourage agencies to go to electronic PCRs, all agencies to go to electronic PCRs. And we asked them what their largest roadblocks were to going to an electronic PCR platform. And the number one answer that we received back is that people felt that they were not computer literate enough to be able to operate it. Now that can be easily overcome by educating them on how easy it is to enter these electronic PCRs. But I really think that that's a large point that's being missed on this, both on the state level and possibly on our regional level, is that we're not educating them that this is not a difficult thing to do. So that's just food for thought.
I mean, 40-something of the agencies have already bought into it. There's a small minority at this point.
Well, it's 47 out of how many 100 agencies do we have?
We've only got, in our region, only got 61, okay. I think.
Okay.
So we're pretty good. Now, I would just, not to correct that, I'm not sure it's bought into, or we're push kicking and screaming. But to that end, we're going out and we've told them we'll come out and do education, or you can come here and we'll walk through this. We've already given them access. The state put up a good thing. They put up a practice site, so you can go in and put in whatever you want, no consequences. So it's an identical site. It's the exact same platform. We put in probably a dozen people that are in there practicing, trying to learn how to do it. But we're happy to go out to the agencies. We try to cluster them, but we're happy to go where we need to go to onboard them with and work with them, or they're welcome to come down here anytime. There's someone here who can help them out. So we're supporting it. We also went out and presented the options. We did a session in Steuben County, mutually inconvenient. We did one in Chemung County, we did one in Schuyler County, just to give them the chance to ask questions. And we showed them the platform and tried to lead them to the water. So I think we've given them the information we can give them, and we're willing to support it. How we got to get them there, we'll get them there. We're doing the paperwork for them. We're taking them there. So we do want to overcome. You're absolutely correct, Rick. That is the resistances, the computer literacy. But I think we can get most of them there, or at least one person per agency on some of those smaller agencies. But we're happy to work with them and get them there. We're not going to turn them on to the platform and walk away and say, figure it out.
The other issue in Steuben is that there are some agencies out there in the rural areas that don't even have, good Wi-Fi or capabilities for internet. There are some agencies that are still on a dial-up. So, speed of downloading and uploading data sometimes could be difficult in some areas of Steuben County. Again, the equipment cost is another concern for some of those agencies, but I think we can get there. It's just, these are hurdles that have to be overcome.
Every time someone comes up with something, we're trying to work with them to knock down the challenge, whether it's connectivity or computer. I mean, there are ways, I think, through, hats off to Sheriff Ballard and Under Sheriff Nellis in Steuben County. they've done a pretty good job of finding money, and I think we can find some money for someone who's really stressed and unable to find the funding to get, if they need a computer or whatever the case may be. I think we can get there, even if it involves MSTAR helping out. We can get where we need to go. We just need to know about the problem and understand it and work through it. But I do believe we can get there. The only thing we can't solve is connectivity. But we can get them to a place that does have connectivity.
But in the meantime, before the next meeting, we can ask them what the agencies that are still withholding, what their biggest reservation is, and see if there's something that we can help. That way, at the next meeting, we can kind of finalize and finish this discussion. That way, we're not, just thinking about it. We can ask them what their actual problems are, and then at the September 1st meeting, we can sit down and just finalize our approach on it then.
Great.
All right. But I have nothing else on the agenda for us today. I think we're pretty good. The next meeting I have listed is September 1st, so that means everyone can have a healthy and happy summer. And this is really, is he still on there? Dr. Sheriff, this is usually your time to shine.
I can see his lips moving. He said, I make a motion to adjourn.
Second it.
All right, so it looks like Kevin and James are motion in the second, and then I'll see everyone in September. Thank you very much.
Thank you, everybody.
Later, everybody.
Thank you.
Have a good summer.
You too, Mark.
You too,
Take
Mark.
care. Is that my daughter? Thank you, everybody.
Very good, thank you.
No, appreciate it. Yeah. You got something? No. That is sweet. I wrote our education guy. I'm like, have you heard?
I'm getting old, Jen, know what you.
Because how do you guys have your standards of care? Is it just a PDF?